I want to look at the issue of single-payer healthcare for two reasons. First, it's a policy for which opposition often argues we simply can't afford it, so the government couldn't afford to provide health insurance for everybody in the country. And second, I think the healthcare issue gets to an underlying but often ignored issue in macroeconomics, which is specifically once we've decided that the government is going to spend to prop up the economy, this generally Keynesian notion, we still have to ask ourselves, how do we want to spend? What kind of Keynesians do we want to be, so to speak? So we'll start by looking at some basic data on healthcare in the United States. First thing you need to know is that the U.S. spends more on healthcare than any other nation. In 2018, we spent 16.9% of GDP. That's about $3.6 trillion on healthcare. That's about a sixth of GDP, or over $11,000 per person. Now, with all that spending, you'd think we'd be getting some pretty top-notch healthcare, but in a lot of respects, we really don't. Despite that spending, the U.S. has fewer physicians than many other countries, about 2.6 physicians per 1,000 people in the United States. And again, despite that spending, Americans visit the doctor less frequently. As you can see here, about 4 physician visits per capita in 2017, as compared to, for instance, Germany, about 10 visits per capita. Now, we might hope maybe that's because Americans are just generally more healthy and therefore don't need to go to the doctor as often, but we can see in the data that's not really the case. The U.S., in fact, fares poorly in a number of basic health indicators, and perhaps the most basic health indicator is life expectancy. Here in this chart, you can see on the horizontal axis healthcare spending per capita, and then on the vertical axis life expectancy at birth in years. And you can see that there's a pretty solid logarithmic correlation for most of the countries we're looking at. Higher spending on healthcare leads to a higher life expectancy at birth, although there are diminishing returns with that. But then you look at the U.S., which once again spends quite a bit more money on healthcare than any other country, and you see life expectancy for this particular country is substantially lower than most of the rest of the industrialized world. We also see that a higher percentage of adults in the U.S. have a chronic disease burden as compared to many other OECD countries, as well as a higher percentage of deaths that are otherwise, quote, preventable with timely access to effective and quality health insurance. So it appears to be the case that despite throwing quite a bit of money at the problem, health outcomes are not very good in the United States as compared to much of the rest of the world. But it gets worse than that. Despite, again, the U.S. spending all of this money, nearly 1/4 of Americans, 78 million people, do not have adequate health insurance. Either they have no insurance at all, or they have insurance, but their out-of-pocket costs and deductibles are unaffordable. And even having private health insurance is no guarantee that getting sick won't lead to financial ruin. A recent survey of individuals filing bankruptcy between 2013 and 2016 found that a majority, 66.5%, cited medical contributors to their bankruptcy, either from medical expenses directly or from loss of employment due to medical problems, or both. That number actually increased slightly after the implementation of the Affordable Care Act. A previous study, in fact, found a similar proportion, 62.1% of all 2007 bankruptcies prior to the Great Recession, involved medical problems, and notably, 77.9%, over 3/4 of those 2007 bankruptcies that involved medical problems, were of individuals who had health insurance. So when it comes to healthcare in the United States, the problem doesn't appear to be opposition to public expenses. As a matter of fact, government spending on healthcare per capita in the U.S. is higher than many other industrialized countries. Instead, the system appears to reflect an insistence that private debt be accumulated for healthcare services, a sort of privatized Keynesianism for those under 65, on top of a traditional Keynesianism for retirees. And I say a traditional Keynesianism for retirees because in the U.S., we actually have a single-payer health insurance called Medicare, but it only applies to those who have retired. The reason we have this is back in the 1960s, it was clear that private insurers were unwilling to insure older people, so the government stepped in to do what the private sector would not. An obvious policy then to deal with the high spending and poor outcomes that we currently have in the United States would be to expand Medicare to those under 65 as well. This would create a universal single-payer program for the U.S., where the sole payer is the federal government taking over for private insurance companies. This would then expand choice and continuity of healthcare providers as compared to the current mostly employer-based system, because that system has at least two faults in that first, the private insurance companies can tell you which doctors you can and can't see, and second, you can lose your insurance altogether if you lose your job. So let's look in a little bit more detail at some of the implications of a policy of expanding Medicare to cover all Americans. A 2020 report in a prominent medical journal called The Lancet found that a single-payer system in the U.S. would reduce total spending on healthcare in the country by nearly $500 billion, $458 billion. Those cost savings would come from a number of different places. About $100 billion would come from standardizing fees for hospital and clinical services, which can vary widely and without a positive correlation to outcomes. That report, for instance, found that an appendectomy can cost between $9,000 and $33,000 in the U.S., and statistically, the more it costs to get that procedure, the worse the outcome's going to be. Another $319 billion would come from consolidated billing and administrative tasks for the service providers, the hospitals, clinics, and so forth, as well as the elimination of unpaid bills. Those expenses to hospitals, clinics, and so forth come out to about $800 billion per year, meaning the savings from a single-payer system would offset the lost revenues from standardized fees 3 times over. Another $219 billion would come from consolidated insurance administration under one government department, the Department of Health and Human Services, which operates at a much lower overhead than private insurance companies currently do. Other savings would come from fraud reduction, negotiating drug prices, and so forth. But of course, there'd be one substantial cost increase, the cost of adequately covering those 78 million uninsured or underinsured people in the United States. This Lancet report estimates that that would be about a $191 billion increase from a single-payer system. But on the whole, that increase would be substantially smaller than the cost savings from all of these other places. More importantly, though, a single-payer system, this same article estimates, would save 68,531 lives per year. And these are based on estimates of the increased mortality that comes from being uninsured. And this is a conservative estimate. It doesn't include the improved outcomes from the continuity of care that a single-payer system would provide. It doesn't include the mortality of the underinsured as opposed to the uninsured. And it doesn't include the improvements that would result from preventive care, which tends to be deprioritized under a short-term cost-focused, profit-maximizing private insurance system. Most of these lives saved would be younger adults. About a quarter of the uninsured in the United States are between the ages of 25 and 35 years, which means a single-payer system would save 1.73 million life years annually. So as you've learned, modern money theory demonstrates that the how will we pay for it question is really asking the wrong question anyways. The federal government creates dollars through spending and faces no financial constraint in doing so. The real issue is whether we make the decision to direct that spending where and to the extent that it's needed. Which means that we can't just think in terms of how much more spending is necessary. We also have to think about the best way to do that spending. In this case, the real question is, should the healthcare provisioning be done through private deficits or public deficits, through households taking on debts or through the government running those deficits? If we look at the statistics, we can see that we already have accepted the social nature of providing healthcare. A recent survey found that 20% of Americans have contributed to a crowdfunding campaign for somebody's medical bills. Most of these people have been friends of these individuals, but many of them have actually been strangers. That survey out of the University of Chicago found, in fact, quote, when asked who is responsible for paying for care for those who cannot afford it, a majority of Americans, 60%, believe that government should, as opposed to healthcare providers, charities, and family and friends. But most importantly, we need to think about whether the systems we create and continually recreate reflect our actual values. In his recent volume, Bullshit Jobs, anthropologist David Graeber notes President Obama's reasoning for opposing a single-payer program. Quoting President Obama, Everybody who supports single-payer healthcare says, look at all this money we could be saving from insurance and paperwork. That represents 1 million, 2 million, 3 million jobs filled by people who are working at Blue Cross Blue Shield or Kaiser or other places. What are we going to do with them? Where are we employing them? President Obama, of course, was more or less correct. The Galvani study estimates that a single-payer system would make almost 1 million administrative positions in hospitals and so forth redundant, and another 750,000 positions in private health insurance redundant as well. Naturally, of course, policies could be developed to ensure that these workers are employed elsewhere. In fact, those policies have already been developed. But at this point in the arguments, we're left with what I think is an important but often overlooked question. If we're all Keynesians now, what kind of Keynesians do we want to be?